As we reconvene from our break, it is my pleasure to usher us into the next critical theme of our forum, public health. This session promises to shed light on innovative strategies, solutions from emerging global health challenges. To initiate us for this vital discussion, we are honored to have Professor Peter Navario, CEO for HealthRight International and Clinical Associate Professor at NYU. Professor Navario is a revered figure in the field of global health, known for his extensive experience in HIV treatment programs and health system capacity building, particularly in sub-Saharan Africa. Professor Navario will deliver a keynote speech titled Preventing the Next Public Health Crisis, Available, Accessible, Acceptable, and Quality Solutions. His address is poised to offer groundbreaking insights and actionable strategies, setting a solid foundation for a subsequent panel discussion. Please welcome.
Thank you very much. Good morning. It's an impressive turnout actually for a Saturday morning in January. Thanks so much to Charlie and World Salon for including me here today. I'm really excited to be part of this panel on global public health and to join a wonderful group of colleagues to talk about really important public health issues in this post-pandemic era. Well, we're not quite post-pandemic. We're still living with the pandemic, obviously, but post-acute phase of the pandemic anyway. And sort of thinking about this fundamental question of how we should prepare for and respond to the next pandemic. And I think a related question that is on the minds of a lot of people, particularly in the public health space, is how do we make sure that that response is as equitable as possible? As many of you know, we've lost at least 7 million people to COVID as of December 2023, and we've had roughly 27 million excess deaths between 2020 and 2023 due to COVID and the knock-on effects from COVID across communities and health systems. Obviously, COVID is just the most recent of respiratory pandemics. Since the early 2000s, we've had the outbreaks of SARS in 2002, H5N1 in 2003, H1N1 in 2009, and other regional outbreaks like MERS in 2012. So naturally, after COVID, we're turning our attention to preparations for the next pandemic. And today I'd like to offer a few thoughts on this important question of pandemic preparedness. This is not new to those of us who have worked in global health for a number of years. But obviously, because of COVID, there's a much broader awareness of pandemic threats and a renewed sense of urgency around identification of solutions and pandemic preparedness. The panel organizers today have selected the WHO's 4 key elements of the right to health as sort of a framing mechanism for our discussion. That framing mechanism suggests that health solutions must be available, they must be accessible, they must be acceptable, and they must be of high quality. So my remarks will touch on response priorities that address these critical dimensions of the right to health. But before I get to that, I'd like to provide a little bit of context for those thoughts and reflections that I have in this post-pandemic moment. I mentioned a minute ago that pandemic preparedness is not a new thing for those of us working in global health. And in fact, you may or may not be aware that disease prevention, particularly in the context of trade, dates back to the 1400s. Official international cooperation around disease prevention and control actually began in the mid-1800s, 1851, with the Paris Sanitary Conventions. The World Health Organization, or those of us in the biz call the WHO, was established in 1948 as sort of a central sort of coordinating global health mechanism to set policy and coordinate global health responses. In 1969, the World Health Assembly of the WHO, so the World Health Assembly is the WHO's policy-making body, So in 1969, the World Health Assembly adopted the International Health Regulations. These regulations stipulate obligations that member states have in the case of an outbreak of an incident of international public health concern. The International Health Regulations were last updated in 2005, and it's important to remember that there are 4 core obligations that member states have under the International Health Regulations. The first obligation that they have is to detect outbreaks of public health threats. The second is to be able to assess the nature of that threat and make decisions about courses of action. The third obligation that they have is to report any public health threats that occur within their borders. And finally, their fourth obligation is to respond to the threat with appropriate prevention, control, and treatment measures. So I think that all makes sense, right? You want countries to have that capacity to detect an emergent infection, to assess its threat, to communicate about that threat, and then to respond appropriately. Very logical. The challenge that we have as a global community is that there are many countries today, roughly 2/3 of all countries that are party to the International Health Regulations, that do not have the capacity to meet those 4 obligations that they have. So 2/3 of countries are, in one way or another, not able to detect, assess, report, and respond to public health threats of international concern. In a deeply interconnected world where borders between nation states are frankly irrelevant, particularly in a pandemic, the inability of just one country to respond appropriately presents a global threat. If 2/3 of countries are unable to detect, assess, report, and respond, then that leaves all of us extremely vulnerable in the case of a public health emergency of international concern. And the response to this shared vulnerability is made exceedingly difficult by the obligations that governments have to protect their own citizens first in a pandemic, right? That is the obligation of a government, to protect your citizens. And yet, this vulnerability, as I just noted, is shared. We saw this in action when high-income governments stockpiled COVID vaccines, while governments from low and middle-income countries struggled to secure doses of vaccine. So given this reality, how do we mount an effective global response that reconciles this unequal distribution of resources, national political obligations, and this common vulnerability that we all share? And so now, with that framing, a few thoughts on what I think we've learned from COVID and other previous pandemics, by the way, including HIV, which really reshaped the global health governance and global health infrastructure, global health financing, and where do we go from here? So let me start with this concept of availability of health services, commodities, et cetera, in the context of pandemic preparedness, and highlight some priorities in this area. This is of the 4 sort of framing principles of availability, access, acceptability, and quality. This one is probably the largest in scope. So I'll just mention a few of these. I'm not going to spend a lot of time on the first one, which is investment in basic research as fundamentally important. Obviously, pandemic preparedness requires the ability to develop vaccines, treatments in a timely manner. And so basic research, investment in basic research is really key to ensuring that we're able to do that. We saw in the COVID response the ability to quickly tailor mRNA vaccines, which had been in development actually for decades, to respond to the pandemic, to produce them relatively quickly, although not with enough volume to meet the total global demand. The other thing that's really critical is to ensure that there are multilateral financing and procurement mechanisms so that low and middle income countries have an opportunity to get access to essential commodities like vaccines in the case of a pandemic emergency. Many of you have probably heard of this entity called COVAX, which was stood up. COVAX is just that. It was founded to give low and middle income countries an opportunity to pool their resources in order to provide common purchasing power for vaccines so that they could secure vaccines and compete globally with high-income countries who have more resources. So it's a pooled financing and procurement mechanism. And it's actually modeled, believe it or not, on what happened in the early 2000s in the global HIV response. In the late 1990s, antiretroviral therapy, which is HIV treatment, came available actually in 1996 in high-income countries here in the United States and Europe. And yet the epicenter of the epidemic, which was in sub-Saharan Africa, and more specifically in southern Africa, folks there where the vast majority, 2/3 of people living with HIV, were unable to access treatment. So these innovative financing and procurement mechanisms were stood up, and you may have heard of some of them, like the Global Fund for AIDS, Tuberculosis, and Malaria, the International AIDS Vaccine Initiative, UNAIDS, and several others were created, again, to attract financing, pool resources, and provide mechanisms that could procure and distribute essential commodities in the case of a public health emergency. And COVAX did that very successfully, in my view, during the COVID campaign. Now, of course, it was created, and they, by the way, they actually were able to secure financing for 10 approved vaccine candidates and were able to secure 4 billion doses, which was the largest portfolio in the world. They did this in a matter of months. The challenge was that they actually got started after the pandemic started. And so the existence of mechanisms like COVAX put us in a much better position as we anticipate the next pandemic. Our experience with COVID also underscored the importance of regional research and development expertise as well as production capacity. When the resources are disproportionately concentrated in high-income countries, low and middle-income countries are at risk also because if those high-income countries limit exports of certain valuable commodities, in the case of a public health emergency, low and middle income countries are left out in the cold without access to those resources. Having financing and production capacity in low and middle income countries is essential, and there are new movements to develop new production development resources in low and middle income countries. So continued investment in low and middle income countries' capacity to do this research and to develop and to produce drugs and vaccines is critical. Only 9 of 46 countries in sub-Saharan Africa today have pharmaceutical manufacturing capacity. And again, this leaves many low and middle income countries vulnerable to export restrictions on essential commodities in the event of a pandemic. Global investment in both health system development and pandemic preparedness in low-income countries is also essential to ensure availability, accessibility, and quality. Continued investment in mechanisms, as I mentioned, like COVAX and the World Bank's Pandemic Fund will be important to shore up low-income countries' ability to detect, assess, report, and respond to future pandemics. High-income country investments in national health systems are also investments in pandemic preparedness. So that is high-income countries investing in health systems in low and middle-income countries, something that we generically refer to as aid or health aid. Economists call it development assistance for health. So these high-income country investments in health systems in low and middle-income countries are also an investment in pandemic preparedness. A functioning health system, particularly community and primary care systems, are essential to any pandemic response. High-income countries must continue to invest in low-income country health system strengthening initiatives that enhance supply chains, health professional training, infrastructure, and strengthen local health-focused NGOs and community-based organizations, NGOs, nonprofit organizations that focus on delivering health services and building health system capacity. Civil society organizations play an essential role in filling gaps left by underinvestment in government health systems. This has been a chronic problem. Global spending on development assistance for health, just so that you have some sense of where we've been, has been since 2009 at about $40 billion a year, although during COVID in 21 and 22, it jumped up to about a little over $60 billion a year to support the COVID response. Many low-income countries and low-income country health systems rely on development assistance for health to support their health systems. For example, in Uganda, about 50% of the health budget comes from non-government sources, from development assistance for health. So the health system relies heavily on donors. That support needs to continue in order for those health systems to function, and ideally additional investment is required. In order to shore up the future pandemic response, economists estimate somewhere between an additional $15 billion to $50 billion is needed to make sure that these countries are prepared to respond to a future pandemic. And based on what funding trends look like, it is unlikely that we would get to that level. So I think given that an additional $15 to $50 billion is unlikely in development assistance for health, we need to think about making our investments work in multiple ways. And so I'm going to talk a little bit about that. What is also clear, in addition to investment from high-income countries into low and middle-income countries' health systems, is that low and middle-income country governments themselves must increase their health spending. Just to give you a sense of, most high-income countries spend around 10% of their GDP on health. Not here in the United States, we're an exception, we spend much more than that. But most high-income countries spend roughly 10% of GDP on health. Most low-income countries spend 5% or less on health. So these health systems suffer from chronic underinvestment over many decades, and in my view, it is the responsibility of those governments to increase their investment. Chronic underinvestment in national health systems has left them vulnerable to the triple threat of infectious diseases, non-communicable diseases like cardiovascular diseases and cancers, and pandemics. Affordability is also a key dimension of accessibility in low-income countries, and governments must provide for financing mechanisms that make care affordable. And in the context of pandemic threats, tests, vaccines, therapeutics should all be free. Out-of-pocket payments are known to significantly curtail accessibility to health services, particularly for marginalized communities and low-resource communities. Finally, it is essential to invest in community-level capacity, not just in the health system itself, to respond to pandemic emergencies. Building a strong, trusting relationship between communities and the local health system greatly enhances healthcare accessibility, acceptability, and quality. This is true in the best of times, and particularly true in pandemic emergencies. Communities with greater social cohesion showed faster uptake of pandemic prevention and treatment measures, and trust between the health system and community members is essential. Community health workers play a critical role in building this trust, as do community-based organizations in many low-income country health systems. And by systematically linking communities to health systems, basically play this essential role. Investment in community health workers and community-based organizations that work in the health space and provide this crucial link between the system and communities is critical and should be a priority for low-income country governments. Community health workers they are the front line of these health systems in low-income countries and are often unpaid. That means that if they get paid work, they often leave, and any sort of training and investment in that role is lost once the person leaves. These folks play a crucial role in low-income country health systems and should be paid a living wage. And that is, again, in normal times, they play a crucial role, but particularly during a pandemic response. As was noted in my introduction, in addition to my role at NYU, I'm also the CEO of a global health nonprofit organization called HealthRight. all of our health, and we do health system strengthening. This is the work that we do. And we focus principally on this relationship between communities, community members, and the health system, and try to find ways to help communities overcome barriers to access to access health services, and once they do access services, to make sure that those health services are of high quality. And whether we're working on health system strengthening initiatives in the area of HIV, or maternal and child health, or mental health, all of our projects systematically link community members as participants in our projects, community leaders and structures, like community health workers, which I just mentioned, and the community health system. So it's sort of that three-legged stool. We employ this three-pronged approach because solutions are more acceptable to the community when the community is part of the design, implementation, and evaluation of those programs, and because those programs, as a result, are more durable and long-lasting than when you employ a siloed investment approach, or just investing in the health system, or just investing in community health workers. And because our solutions reflect local needs and local priorities, and the community is in direct contact with the health system, the services ultimately have greater impact. Finally, this community-centered approach is essential when there is a pandemic threat and new vaccine and prevention measures are implemented because of the trust that this approach builds. Communication and trust are vital in pandemic response, particularly in an era where misinformation and disinformation are so common and can lead to tragic consequences. We saw this in, some of you may be aware of some of the killings of polio vaccine workers, which is horribly tragic and is a result of mistrust of the health system. I'd like to address one final issue that until recently has been totally overlooked in global health, and that is an investment in mental health. A strong mental health system can increase resiliency in the face of global health threats and are an essential component of pandemic response, where we see increased levels of anxiety, depression, and PTSD. HealthRight's been working on building mental health capacity in low and middle income countries since 2006, and we've worked closely with the World Health Organization to increase the availability of low-cost, highly effective, and scalable mental health interventions that are designed specifically for low-resource settings. These interventions do not require trained mental health professionals, show strong symptom reduction for folks who participate, who have mild to moderate symptoms of common mental health disorders like depression, PTSD, and anxiety. We found particular success implementing these interventions in community settings, increasing their accessibility, acceptability, and quality. Investment in mental health remains far too small. If you compare the global disease burden caused by mental health, it is among the top 10 drivers of global disease burden, and you compare that to the level of funding available, it is wildly out of whack. For example, we spend globally on the HIV response somewhere between in a typical year, between 12 and 13 billion on HIV prevention, care, and treatment. And we spend only just a couple hundred million on mental health. So a tiny fraction on mental health, and certainly not commensurate with the disease burden that it causes. So, and I want to be clear, I'm not giving that example to argue for less investment in HIV. It is to say that we need much greater investment in mental health and building the capacity of these health systems to deliver mental health services. So with that, I will close my remarks. Thanks again for having me here. Hopefully some of that framing around the global health space that we're currently in, this sort of post-pandemic, or yeah, I guess you can call it a post-pandemic moment. It's still going on, obviously. But how we're sort of thinking about this and anticipating the next pandemic with issues of equity around accessibility, acceptability, quality, and so thank you very much. And I think with that, we're going to call the panel members up.